Good morning. Today we're looking at the assessment of the newborn. So this is a brand new baby, straight out of the womb. What I intend to do in this session and the next session, which is an assessment of an under 28 days old baby, is to give you a greater understanding of the child, of the process of resus, also increase your awareness of the physiology, take a structured approach, and structured history taking as usual. So, first of all, I need you to know what we mean by the different terminology. So, this session is about a newborn. Now, you will find that in different textbooks, and different people might give you alternative terminology. For the purpose of this course, OMED 1401, I want you to think of a newborn, meaning the baby has just been delivered, the placenta is still in the same room as the child. So I will call that a newborn baby. A neonate, on the other hand, is a very, very tiny baby. So they're up to 28 days. So that's after birth, obviously. Those are the two that we're going to consider. Apart from that, everything has been put into pediatrics. So these sessions of newborn and neonate are specifically for the brand new babies. So let's go on and let you know how to do an assessment of the newborn. First things first, you need to know what happens when it all goes wrong. So with the newborn assessment, you will be there in the obstetric condition with mum giving birth. Well, you're not giving birth. I mean, you'll be there when mum's giving birth. Most of the time with this, all you have to do is stand there, catch the baby, clamp the cord, dry the baby, give it back to mum. Hopefully the midwife's going to be there with you, but certainly on most of the babies I've delivered, there was no midwife. So quite a lot of the time you might find yourself on your own. Now, to some people that's really, really, really daunting. There's a lot of things that can go wrong. We'll cover some of those in the obstetric, but you cover most of the things in regard to emergencies on Richard's course, OMED 1400. So for today, first of all, ensuring we know how to resuscitate a newborn baby, and then afterwards, the normal assessment, which hopefully is all you'll ever see. Right, let's get our mind set on resuscitation first of all. I want you to know this off by heart, because when you're there, you will be panicking if the baby comes out and the baby's not breathing. I've been in the situation a couple of times, and it is the most scariest thing. And everyone's looking at you going, do something. Now, thankfully for me, both the babies that I've delivered that have been lifeless, floppy, have made it. So hopefully with a little bit of confidence behind you and a little bit of know-how, you will not lose it if you see a baby come out limp and floppy and blue. So my advice to you is learn this, know it, know what can go wrong, how to fix it if you can do, but also get the app on your phone and revise it on the way to the job. And I mean that for any delivery. I don't mean it like when you think that, the baby's in danger of dying. I mean it every time you're going to an obstetric call, be prepared to resuscitate the baby. Okay, so there are three main areas which cause the baby to come out in arrest or to need a little bit of help to breathe, which is the better way of putting it. So first of all is hypoxia. Now, I've told you with pediatrics, especially with the smaller ones, the main cause of arrest is hypoxia. They will die from a respiratory arrest more often than a cardiac arrest or trauma, unless, of course, there's a pre-existing condition that might cause a cardiac arrest. So we're thinking constantly, we need to be delivering oxygen. This baby needs to be able to breathe. That's what's going to keep it alive. It's not going to be necessarily, usually, it's not going to be drugs. Usually it's not going to be CPR. Usually it's not going to be shocking. It's most of the time going to be your ventilations. So I want you, when you're in the skills lab, to know what the tiny little bag valve mask feels like. to know how much how little, sorry, I should say, you have to press the bag in order to inflate. I want you to know the difference between inflations and ventilations. I want you to know why the lungs might not be working. So there's an awful lot of work that you can do behind the scenes on this topic to make sure that you're feeling all right with it. What we're doing, as usual in this course, is giving you the need to know. But as I always say, you can go way further than the information I give you. So you can look up meconium, you can look up surfactant in the lungs, you can understand why hypoxia is so common in the newborn. All right, so a couple of the things that I've popped in here are the most common ones, common causes of hypoxia. So you can imagine with the umbilical cord complications, the oxygenated blood is what's keeping the baby alive while it's in the womb. When it's coming out of the passages, it's still relying on the umbilical cord and placenta to get its oxygen. When the baby is born, um, you're going to be thinking about cutting off the cord, cutting that supply, and you're hopefully going to be getting the cry from the baby. Now, unfortunately, sometimes the baby does come out with the cord wrapped around its neck. And that is an emergency, obviously. The baby normally comes out head first. So when you see in the head, first of all, you'll see crowning, and then it takes a long time for the head to come out. And then before the shoulders are delivered, you might have a little look around the neck to see if you can see the umbilical cord. You're going to have to loosen that and unloop it around the head because that will choke the baby. So just touching the surface on this, like I say, you're going to learn more about umbilical cord emergencies in Richard's course. But be aware that the newborn can die from strangulation via its own umbilical cord. A prolonged delivery, you can imagine the baby going through the passage to make its way out to the outside world. If that takes longer and longer and longer, it could be that the umbilical cord is squashed or compromised. It could be that the baby starts to panic. And the longer it takes, the more likely that the baby might be subject to hypoxia. And lastly, placenta issues. So in the obstetrics session of this module, you will be learning about placenta emergencies. So that would be placenta previa, placenta abrupta. So what these conditions are, or when the placenta comes away from the lining and you get bleeding. So it's either concealed bleeding or it's actually PV bleeding. Either way, if the mother is losing a lot of blood, the child is going to get less oxygenation because there's not enough oxygenated blood in the mother to feed the child the oxygen it needs. So if you're very confident and very aware about obstetric emergencies and you know your stuff about placental emergencies, you might be able to see that as a potential for the baby coming out hypoxic if you've diagnosed placenta previa, for example. So you will learn about that in a later chapter. So thinking hypoxia first. When you're thinking about hypoxia, remember all of the stuff that you've learned on this module already. What does hypoxia look like? You know, it's not just sticking a SATS probe on somebody. It's not just counting the respirate. You should be able to see what hypoxia looks like. And I would expect you to know that by now. So just pause for a second. Pause me if you like, if you don't want me staring at you. And think about what hypoxia looks like. So I'm thinking about cyanosis. That's my main thing that's going to come out. You see that baby's head coming through the vagina. Now, most of the time it's covered in gunk. And by gunk, I mean like amniotic fluid. It can be white. Sometimes there's a little bit of poo in there. Often there's blood in there. But the baby in general is a kind of a reddy, purpley colour with like white crusty bits on it. The baby coming out blue, you're thinking hypoxia. You're thinking, right, mate, get the oxygen ready. We might need to oxygenate this baby. So looking at the signs of cyanosis. Moving on from hypoxia, we want to think about fetal compromise. So again, that is the non-development or the prolonged time in delivery. How has the baby's body developed enough to be able to breathe for itself? So As you know, the baby obviously is forming in the womb. So those newborns that are preterm, so less than about 35 weeks, they can easily have complications with their lungs not being fully formed. Now, what happens inside the canal is that the baby's lungs are full of surfactant. The motion, ow, I just bit my cheek. The motion of, oh, sorry, hurts. The motion of the baby being delivered through the birth canal, that squishing normally squishes the lungs and squishes the surfactant out so that when the baby is delivered, they go, wah, which is the sound that you will grow to love and be absolutely relieved at when you hear that screech of the newborn. It means brilliant. They're not in arrest. Anyway, I digress. So those babies that are born quite early might not have fully developed lungs. They might not have been able to get their surfactant out because the squish level, not very technical words, the squish level is not as much because the baby is smaller. So therefore, the surfactant might not get pushed out of the lungs. So bear that in mind that the lungs might be full of stuff. I haven't written it here, but we've got a whole section on meconium a little bit later on. So if you can imagine a baby in distress might have its first poo on the way out in the birth canal. That can get aspirated. So baby swallows it. Then that's gone into the lungs. So meconium in the lungs is obviously that's going to give you hypoxia, and that's going to be a development issue too. So breech babies that are in the upside down position, that can be a compromise that is going to cause an arrest as well. Starved of oxygen, in distress, tachycardic, that can lead to too much distress and an arrest for the baby. Maternal infection, which we will come on to later on again. Just to touch on it now, is that would be something like a sepsis in the mother. And of course, you can imagine everything that's building that baby comes through the mother. So if the mother's got diabetes, the baby's going to have a little bit of diabetes before it grows out of it, like in the womb. If the mother's having infection, sepsis, that's going to get passed on to the baby. So think about what's going on with the mum as well. And if the mum's really, really unwell, you could have a baby that is birthed being very, very unwell as well. So we do have a section on newborn sepsis, things to look out for. But I think you guys are getting pretty hot on sepsis and septicemia anyway. And then the other things which are unfortunate for the baby and not an awful lot you can do about it. So a baby can be born with infection that could cause them to go into arrest, respiratory or cardiac arrest. You can also have sudden infant death syndrome. And to us, we wouldn't know. There's no reason maybe that this baby is birthed and is stillborn. There's not often a reason that we can put our fingers on to say why this baby hasn't made it. So you don't have to always be thinking, what can I do to recover? If the baby sadly has been born stillborn, there's not an awful lot you can do. Now, there's a load of studies on this about closure, and paramedics often disagree. This might be one from Marlon's course, in fact. They talk about when babies have been born permanently sleeping, or whatever way you want to call it. If you go through the motions of trying to do a cardiac arrest, it's said to give greater closure to the parents because they've seen somebody try to bring their baby back. It might be futile. You might completely disagree with that, give you false hope. For me, that's not something that I'm going to tell you about, because I think that's very, very personal, and I think it's what you feel at the time. Right, so hypoxia, we can do something about. So bear that in mind when you're thinking about the newborn resus. You can get a hell of a lot of information from the resus council guidelines. They're going to give you everything you need on it. So I have linked to several parts of the resus council guidelines in this. So what I would say to you is when you're going through this, I'll pop the static PowerPoint on as well so that you can click on the additional info whenever you're making your notes. Um, excuse me. Always have the app open at the same time. Right, so these are what you need to know. Sometimes you need to do resuscitation. Most of the time, you just need to help. Okay, so newborn life support is resuscitation, but sometimes all of you're doing is assisting the transition. So you'll see words coming up. Here it is, placental transfusion, and well, actually, it's not in this bit, but you assist the transition. That means the baby hasn't come out completely breathing yet, but something you do will cause it to breathe. Now, one of the two that I had that were born not breathing, all it took was me drying the baby to bring it to life. That's why when the baby comes out, sorry, I'm jumping ahead again, but it's important in my brain at this time. When the baby comes out, if it's not breathing, you are still going to dry it anyway. You're not drying it for aesthetic reasons. You're drying it, number one, to stimulate it, and number two, to keep it warm. So sometimes if that baby is not breathing when it comes out, you get in the towel, you're drying it. You don't do it all nicely. You're drying it quite roughly around its chest. Sometimes that action, and I've lived this, is enough to make the baby take its first breath. Bear it in mind. Okay, so the Resus Council guidelines now has suggested that we need to delay the clamping of the umbilical cord. So when the baby comes out, it's an action that everyone wants to do. You know, you see the baby there, you're like, oh, it's a lovely baby boy. And then on the TV, all that happens is cut the cord, there you go, give the baby to the mum. And of course, on TV, the baby's already dry and doesn't have all this stinky juice all over it. In real life, it's a little bit more messy than that and a wee bit more stinky. So when the baby comes out, I don't want you cutting the cord straight away. You're going to put the clamps on the cord when it's time. So delay by 1 minute. When you go to the additional info here, I shouldn't have clicked that. Good, it's not working. Ah, damn. Yeah, when you go to the additional information, that will take you to the reasons why you need to delay clamping the cord. So delay by 1 minute. Dry the baby, talk to the parents, tell them how the baby's looking, do whatever you need to do, which hopefully is not resuscitation. Then a minute later, you're going to clamp the cord and cut it. Little word to the wise here from the deliveries that I've done is when you're clamping, clamp one, squish the blood out of the umbilical cord before clamping the other so that this is flat, the cord's flat. When you cut it, it'll be nice and easy to cut. Whereas if you go clamp, clamp, and then cut, and there's blood in there, you're going to get a little gunky shower. Yuck. Okay, so delay the clamping of the umbilical cord. Dry, cover the newborn infant, and take steps to maintain a normal body temperature. This is super important. And I am coming into this in a different slide, but the baby is going to lose so much heat as it comes out, as it's delivered. You can imagine how lovely and cozy and warm and snug it is in the womb. And then you're brought out into the outside world. And we know the socioeconomic state of a lot of people that don't necessarily have a midwife booked, don't have a hospital, might not have been communicated or understood the instructions for delivery. They might be just sitting there and having their baby in their cold, freezing, poor, dirty home. So it's up to us to make that as safe and warm as possible for the newborn. If it's completely freezing, take them to the ambulance, shut all the doors, shut the windows, get the heating on. And I'm not exaggerating. In certain homes that I've been into as well, we've opened the door and put the oven on. It needs to be a lovely warm environment because the baby will lose loads of heat really quickly. I will tell you a little bit more about drying the baby once we come on to the keeping the baby warm slide. Right, assess the condition and the need for any intervention. Simples. Look at it. Do we need to do anything to help or not? Maintain an open airway. Consider positioning. So, as you know, the pediatric, the baby especially, has got a large occiput. So, therefore, if you are going to have to resuscitate the baby, you're going to have to put some pillow or a blanket, something under the shoulders to get that neutral alignment of the airway. Make the airway not kinked like that. Baby's head, baby's body. You can imagine the airways kinked like a straw there. So nice and flat for the baby. That might be enough to open the airway to make it start breathing again. It might be, it probably isn't. Have a look in the airway. Okay, you're looking for things like meconium. So if the baby has been in distress and has had its first poo on the way in the canal and has aspirated that, you might see some signs around the nose and mouth. And that's a bad thing because it's probably aspirated and gone into the lungs. But at the same time, it's not impossible. It does not mean the baby's going to go into cardiac arrest. So if you need to get anything away from the nose and mouth, then do so. If the infant's not breathing, you're going to give inflation breaths. Now, I've written here air, not O2. So I know some of you got the chance to practice newborn life support and some of you didn't last year in Nurse 1376 Scott's course. So this might be a bit peculiar to some, but what we want is just inflation. So there's no exchange of gases. All you're doing is inflating with the tiny bag valve mask air. Do not plug it into the oxygen at this stage, just air. Okay? That's what you're going to do first of all. Then you're going to move on to your cardiac arrest algorithm. So looking at if the breathing's effective, looking at if the heart rate's effective. When it comes to heart rate in the baby, you're probably going to have to do this with your stethoscope. So you're going to be listening to the heart rate and trying your best to work out what it is. Now, a brand newborn heart rate is probably going to be over 150. When you take the heart rate, if you're listening, you're really not sure, and you hear it, and you're like, oh yeah, I think it's about 60 or something like that. Don't rejoice, because a brand newborn baby with a heart rate of 60 is not adequate to sustain life. You can't say, baby has got a good heartbeat. No, that's not good enough. You have to start CPR. And that might feel a little bit wrong to you. The heart's working. The baby's got a heart rate. 60 is not adequate. So whatever you do, remember that when you're going to obstetric calls. So a brand new delivered baby, you're trying the ventilations, you're trying the inflations, you're doing everything you can to reverse hypoxia, first of all. But if the heart rate's not adequate, you're starting CPR. Now, anyone that's done CPR on a baby or child, which of course I have as well, it depends on the size of the baby, how you want to do the CPR. So I have done CPR on a neonate that didn't make it, but not a brand newborn. But the neonate was small enough to look like a newborn. So for a newborn, what we're planning to do is encircle the chest and the back. So what that means is you're putting your hands around the baby. This is where you're going to compress like that. You're squishing in together. So your thumbs are on the chest between the nipples. Your fingers are on the back. You're squishing like that when you're compressing. When the child is a little bit larger, or you're carrying the child out to the ambulance, you might be doing it with two fingers. All right, but for the brand newborn, we're thinking of the circumferential. So we're just surrounding the heart and compressing it that way. You don't have to press down very far. It's a third of the depth. So that's going to take not much effort at all. It's quite hard to do that whilst managing this big floppy head. So please be aware of the airway. If you can, don't do this on the go. It's really not good practice. Sometimes you have to because you have to get to hospital, but it's more likely that you're going to be able to successfully resuscitate this newborn at the home, circling whilst the baby is lied down. One person on the airway, one person doing compressions. So we're used to doing 30 to 2 in adults. In newborns, it's 3 to 1. Why do you think it's 3 to 1? Well, it's because you want to get more oxygen in. Okay. Get the child a little bit older, that turns to 15 to 2. You'll see in other countries do it differently. But for us in the UK, we're doing 3 little compressions to 1 ventilation. And it's so gentle and light. So please don't overpress. Please don't overbag. Yeah, we barely administer drugs to babies. We really do. I have never given a baby a drug, a newborn, and I have never shocked a newborn, and I have never intubated a newborn. It's about the simple things and doing them effectively. So let's move on to the Resus Council guidelines. Here we are. This is the page, and hopefully you can go through that. So, first of all, if you find the baby in cardiac arrest, you still have to go through the motions of drying the baby. Like I said to you before, this might revive the baby. It has been done. I have been there. I have done it. It's like a miracle. Drying, properly drying the baby. Make sure it's dry all over. Get rid of that towel. Get another new towel. Baby, are you breathing? Baby's not breathing. Right, okay. Let's assess the tone, breathing, the heart rate. If the baby's not breathing, set the baby down, open the airway, check in the airway. Is there anything we need to get rid of? If there's nothing there, we're giving 5 inflation breaths. Okay, so you might be able to have the tiny OP airway. If you don't have that, just get on with it. All right, so the smallest bag valve mask that you've got, it's probably got a circular mask rather than the pointy one, and it's probably located in your maternity pack. When you go on placement next, ask your mentor, where is the newborn bag valve mask? So hopefully it's in your maternity pack. If you've never opened a maternity pack, open it. I don't care if it's sealed. You need to know where these things are. Someone will kill me for saying that, but I live by it. Right, so inflation, no oxygen. 1, 2, 3, 4, 5. Check again. That might be enough. You're forcing a little bit of air into the lungs. That might be enough to kickstart it and get it working. You guarantee that if that does work, the baby will be like, wow! And yeah, everyone will be like, yes. If that doesn't work, you're going to have to keep going. So reassess everything. Airway, head position. Let's start doing our proper compressions. So let's check the heart rate. Is there any chest moving in terms of breathing? Is there any heart rate? If the heart rate is not detectable or it's very slow, we're going to first of all try the oxygen again. So everything we're relying on first of all is oxygen. Plug the oxygen in this time and let's ventilate. Just for 30 seconds. Just ventilation. Please God, this will work. Or whoever you want to pray to. Baby doesn't breathe. Right, let's assess the heart rate. Heart rate's under 30. Right, start CPR. 3 to 1. 1, 2, 3. 1, 2, 3. Get that metronome on if you possibly can. Use it on your phone, do whatever. Reassessing all of the time. So it says here, reassess every 30 seconds. So you're not waiting your 2 minutes, you're waiting your 30 seconds. And then think about what else you might need to do to reverse. So we're mainly thinking about the inflation breaths, then the ventilation, and then going into your CPR ratio of 3 to 1. Hopefully this will work. Okay. You might want to pause it there and take a little break because that's heavy. It's not a nice thought. It's not nice to think about having to resuscitate a brand newborn baby. But if you've got the drill in your head and you don't need to go, oh, what was it again? 5 inflation breath, oxygen or not? Something about 30 seconds. Oh my God, what's the heart rate again? You need to know that off by heart. Your pets need to know it as well. Maybe they don't. That's not your lookout. You're responsible for yourself. You boop, boop, know that place. Okay. Now, let us move into calm land. And this is just the normal assessment of a newborn at birth. All right, moving away from the cardiac arrest, you've got that in the back of your mind. But thank goodness this is a normal birth. So, the way that we do this for OMED 1401, it starts off the same as the pediatric assessment. And then we're going to move into the actual assessment of the newborn. So I'm going to do this on a separate recording, bite size. Somebody told me I need to do. So therefore, I will see you in part 2.